our first case, we're really trying to kind of think big picture. And so I say that mostly because I also have trouble not getting in the weeds sometimes with case vignettes. So we're really trying to think about kind of bit larger scale implications. So I'll read this and you can follow along. This is a 10-year-old boy who has Duchenne muscular dystrophy, actually kind of similar to the hypothetical case that Tina posed earlier this morning. But this is a boy who is not amenable to existing exon skipping therapies. He's ambulatory, but he has his mobility limited by significant ankle contractures. And so he's slated to have surgical correction of these deformities with an expectation of prolonging ambulation or facilitating ambulation. But while he's awaiting this surgery, he becomes eligible for a placebo-controlled phase 3 clinical trial of a gene therapy agent. This is where I'll ask you to kind of suspend disbelief a little bit, not ask too many questions about, what data do we have and what's his exam, and just kind of stay big picture. So participants in the trial are unable to have major surgeries within 1 year of receiving the therapy, and he and his family are coming to you asking if they should delay or cancel the surgery. And you can see below some of his the results of his evaluation and kind of where he's at.
We had a couple different discussions, I guess. One, like for this child, was sort of set up as what sounds like a very weak child, and considering a surgery, and there's a lot of, if we get into the weeds, of what that would mean for this child. I don't think this child would walk after a surgery necessarily, so my initial inclination is just to say, don't do that, right? Like, just stop. But maybe that's too far in the weeds. Our other discussions, I think, are a little more hypothetical on some of the ethical and sort of deeper questions you put on here about, potential benefits of a trial versus. You lost me. It must be done. So this concept, and we do face this, I think, right now in the clinic, is you can go on this trial, which might benefit you. We can do this procedure, which might benefit you right now. And how do we balance that? And I don't have a good answer for that. I don't think we have a good answer for that, other than providing good information to families and letting them decide. So that's kind of where we left that.
Is that similar to what other tables were saying? Yeah. Did anyone take it in a different direction? Yeah.
I think we were similar, but I think, just as you said, it's not either of, we know the surgery's probably not going to help. So the trial may. So I think in this case, it's a no, why don't you do that? Because I do think there's that psychological, well, you didn't let me do this trial because we get that a lot now in orthopedics, like, because a lot of selection criteria are you going to need surgery in the next 12 months or 18 months, which is hard to know. But, from the spine's the biggest one that we deal with, are they going to need spine surgery? But hopefully from the talk earlier, usually it's not something we have to do in a year. That's the good thing with scoliosis, is usually it's not rapidly progressive. Sometimes it is, but usually a year. Yeah, sure. Do the trial, see where you are, and then usually the family's lost their hope. It hasn't gotten better, and then they do the surgery without that pressure or guilt of, we weren't able to do this new therapy. So
I want to also add to that, there was also this psychological and social pressure of being in a trial. There's so much social media saying, this child did this child did this, unskippable. But again, that data is biased. And you enter a trial, there's no real data information out there for this one trial, for this one entry into a trial. And I think orthopedic surgery can wait. And there's options of serial casting, nighttime bracing, bivalves that can bridge the timing for serial casting or surgery.
And now have 3. Yeah. Yeah.
No, it was just the same as Breakout.
Did anyone end up talking about kind of how you would communicate this, or how you would make sure that the patient and his family, so the patient is, a child, and so how you talk about some of this with him and how to make sure that he understands that it is as informed a consent as possible. Was that something that any tables talked about? Kara, you have the mic.
I did have the mic, but we did not
Hot
talk
potato.
about that. I was just going to play like a little bit of a devil's advocate for the last discussion. Our table was overall in support of going with the clinical trial for the same reasons that my colleagues have expressed, with the one caveat of, why is this family thinking about a surgery? Because they hopefully will have been presented with that data that he might not be ambulatory afterwards. What is the goal of it? And really just wanted to emphasize that if it is for debilitating pain, that just might be one of the reasons to consider going through with it. I don't think that is usually the reason they go to surgery, but just to say it out loud. The other thing I just wanted to consider is, if it's phase 3, hopefully there's some data on adverse effects, and, those should be appropriately weighed as well. And then finally, really more in support of the clinical trial, as again, our table was is ambulatory status a part of that? Does he have to be ambulatory, in which case that would be a hard don't do the surgery? And is there anything else in the pipeline, and does ambulatory status affect that as well? So something else to consider.
A lot to juggle.
Coming to your question, we didn't discuss it, but one thing I have seen is I think it's important for the families and kids to know what the trial is going to entail, and I'm hoping that if they were offered it, they know that it's going to be, you have to come every 3 months, you're going to be assessed, you're going to be, because that is a lot on the kids, and I think it is important that the family knows that up front and that the kids weigh in on that with the family.
I was just going to add. I was going to add two things, starting with the second question that you had. I think one of the things that's been challenging, on the informed consent aspect is normally it's not being run by an orthopedic surgeon. So usually they're getting the informed consent for the study from one person, and they're getting the informed consent for surgery from somebody else. And trying to weigh those two, or how those two are communicated, I think is very difficult for that. Like, which is better for this family? We're simple people. If you send us somebody with a tight tendon, the first thing we're thinking is, I can cut that tendon. And seriously, that's how orthopedic surgeons feel, and especially who you're sending that to, because a lot of times I think we get sent the folks of, well, why don't you just talk about, we see this a lot in cerebral palsy. They come to see us first, and orthopedic surgeons diagnosing them with cerebral palsy because nobody wants to tell the family they have cerebral palsy. And so in this case, you other medical physicians may know that surgery is not a good idea, but rather than saying surgery is not a good idea, you send them to the orthopedic surgeon, where some of my colleagues just cut. If there's something tight, we cut, and we don't. Why'd you send them to me then? And so I think you have to weigh all of that when thinking about these things, because not everybody's not going to just do it, even if it's as sad as it is to say, in the best interest of this patient, if they're not educated in dealing with these patients.
I think this table was talking about kind of meeting as a whole team and kind of multidisciplinary care. Who's our spokesperson here? You're closest to me. I'm just going to give you the mic.
Yeah, I think that was a echoing statement over here, that the family there's a lot of questions that need to be answered, and bringing in all members of the team, whether that's therapies or orthopedics, social work, and really just getting that grand picture of what are the patient and family goals and what are the potential outcomes that can lead to those goals.
And then I'll be quiet on this. But it is, the problem with orthopedics is it's visual. You can see the tight heel cord. You don't see the neurology. You don't see the muscle pathology. So no matter how many times you tell the family he's not going to keep walking, they're thinking the problem is he can't get his foot flat. We get it flat, they're going to walk. It's the same. It's the same thing we deal a lot with, not just with these folks, with kids with cerebral palsy, again, of They're not ambulatory. Me putting their hip in the socket's not going to make them ambulatory. It's a neurologic problem. Yes, it has orthopedic complications, but that's not why they're not walking. And so it's just really important, I think, to remember that, because no matter how many times we have those discussions, their hope when they're having orthopedic surgery is that he's going to walk.
Form and function conversation that we had earlier today. Any other big thoughts before we move to our next case?
I think it just drives home the point of communication. I feel like, study-wise, the PI would be communicating with you as the orthopedic surgeon and saying, hey, looking at what we're seeing now, do you recommend any other procedures so that we can anticipate it within 12 months? But the same thing with surgery here, like it would be, you would think there'd be a communication looking at their time velocity test, talking to the PT, what's their strength at their hips, at their knees, and how will that change the mechanics on, will this take them off their feet entirely? I mean, all of us are agreeing yes, but I think, in general, the communication's huge, whether it's a trial decision or a clinical decision. But the one thing that we said here, first and foremost, regardless of the trial, we have to treat the patient for what they need, and then the trial in itself is a secondary. But again, of course, knowing what their primary goals are, because if you don't do the surgery but then they don't qualify for the study anyway, now everybody's unhappy. So
Perfect, thank you. I think we are right on time actually to get started on the next case.
I'm going to start off with our girl, who is a 4-year-old with SMA type 2, 3 copies of SMN2. She has a flexible scoliosis with a left lateral curvature, a moderate kyphosis, bilateral hip subluxation. She is sleeping well with no concerns for snoring or orthopnea. Range of motion is within normal limits, except she does have -5 degrees of knee flexion contractures, -5 degrees of knee extension. She was treated with Zolgensma before her 2nd birthday. And her motor function testing scores, her expanded Hammersmith was 25 out of 66. She was able to roll independently, transition independently. She crawls in the home. She can transfer in and out of her manual wheelchair that she self-propels in school with no fatigue. She stands with support. She has not determined a hand dominance yet. She requires mod assist with dressing, self-feeding. Mod assist with dressing, but she can self-feed and does not have any concerns with eating or drinking. She does have a history of articulation difficulties, with her intelligibility being about 70% as per the speech language pathologist. She gets PT and OT once a week, and her equipment includes AFOs, a kid walk, a TLSO that she doesn't tolerate, a zippy manual wheelchair, a stander that's not being used, and a Riften chair at school. Now before speaking about her, I'm going to introduce you to her father, who's a 26-year-old male diagnosed with SMA after his daughter was diagnosed at 23 months old. He has 4 copies of SMN2. He also has type 1 diabetes with an insulin pump, obstructive sleep apnea, and reports daily choking episodes with water. He was treated with risdiplam right after his diagnosis. His motor function, though, you can see he's quite high functioning, as he did not realize he had SMA until his daughter was diagnosed. He topped out on the revised Hammersmith score, scoring a full score. He walks 627 meters. He goes on different walks and hikes for an hour and a half to 2 hours, 3 times a week. He does report exertional fatigue in his hip muscles and sometimes a waddling-based gait, and mostly reported in the recent years needing to lean on his golf club more often when he was out on the golf course. No therapies and no assistive equipment. And then lastly, this is now brother of our girl. This family had a new child with a 2-month-old brother, and he was diagnosed with SMA in utero with 3 copies of SMN2. He was given a risdiplam bridge till he got Zolgensma at 19 days old. At 2 months, he was evaluated with the CHOP INTEND and got a 58 out of 64. He had active anti-gravity movements of his limbs, was able to lift his head in prone, and is not receiving any rehab services and has no adaptive equipment. So because this is a lot of family history and you have that on your table, we're going to give you more focused questions. So for our girl, how might you monitor or manage her orthopedic concerns, including her scoliosis and kyphosis, hip displacement and contractures? What are appropriate rehabilitation goals given the treatments that she's been on and the gains that she's been able to make? And what can we anticipate her trajectory being? And then are there any additional interventions you would consider? For Dad, we want you to think about what rehabilitation or exercise programs you might recommend, and what are the considerations for needing to manage his fatigue, and are there any additional recommendations or referrals you would make based on the case? And then for Brother, what additional info would you like for your assessment or evaluation? How might you monitor his development or progression? And when would you want to pursue formal rehabilitation services? And then lastly, kind of thinking of this family as a whole, how might you manage them in a multidisciplinary team, and what are realistic expectations for them to follow through with?
We kind of neglected the little girl because we focused on the dad and the baby, but our one thought on the little girl was regarding her drug therapy. Getting her gene therapy at 24 months old was really far along, and that we think she should go on something else. We suggested risdiplam just to coincide with the rest of the family. And I think with the TLSO.
No, we're just like, forget it. Well, we were kind of joking around and saying, like, oh, is she gonna wear it long enough to make it worth the fight? They have a lot of things.
I did have one other thing. Yeah, kind of similar to what we said yesterday with the TLSO. Like, is it really worth it? Probably not. I also saw mentioned she doesn't use her stander, but she does have a kid walk, so we're curious, like, is she more interested in her walker? You can get in a lot of standing and walking and functional mobility in the walker, and that will also, help address some of the orthopedic concerns to an extent. So that may be a motivating way to get at some of those things.
Some thoughts here?
In addition to that, we had thoughts about possibly intervening with maybe a standing power chair. First of all, assessing why is there decreased compliance with the use of all her equipment, including the stander and the TLSO. Yes, there's always decreased compliance, but the stander and the gait trainer. And so if we were to move into a combo use of a manual chair and a power chair, and